Welcome, welcome. Thank you very much for tuning in tonight. My name is Peter Bates, and it's a welcome from OrthoHub. And thank you for turning up to this webinar on ankle fractures, brought to you from OrthoHub, which is a new thing. Cash, Mike, Ramon, and I are trying to set up this website, which is with the basic functionality of free, interactive orthopedic education for everyone, not just clinicians, but patients, therapists, and anyone involved in orthopedics, really. We're live on social media, as you know, and we have a number of things which already started off with a few podcasts. That's where the OrthoHub thing started. Cash and I did a few podcasts, and then we've got some other people to do them, and they turned out great and got loads of hits. So try those out if you've not. We've then moved on to webinars. We've got some little videos. We've got some how-to videos, and we've got some totally cool stuff coming up, which we're just working up and finishing off now. So there's loads more to come, and we're slowly bringing it all online. So please just keep an eye on what we're up to and try out some of the podcasts. But there is a bit of swearing in there, so just brace yourself beforehand. Don't play them loud in front of your mother. We've got some other stuff, some other webinars coming up 2 weeks' time when bone goes bad. We've got Herman Sharma, David Goodyear, Nima Hadari. These are all big guys in the limb recon scene. This is like tibias with pus pouring out and all that stuff. Wonky legs, infections, osteomyelitis, bone infection, all of that. And then 2 weeks after that, 4 weeks' time, we've got resilience. And resilience, I think the best way of, the importance of resilience is becoming increasingly evident to us because we see what happens when one is not resilient. When we are not resilient, we really feel, the effects of that, and it can be incredibly damaging, not just to our work, but to our personal lives and everything around us. So it's hugely topical, and we've got some absolute experts talking about that as well. So that's the next month's worth of content going down, plus the other little bits and bobs around the side. But today it's ankle fractures and Lis Franc injuries. And again, I don't know how we do it. We are not paying these guys any money, I promise you. But we've got an awesome faculty. We've got Hiro Tanaka, Lyndon Mason, and Jitendra Mangwani, all massive players in the BOFAS, British Orthopaedic Foot and Ankle Association scene, and they are all taking on a different section, which is really exciting. Before I go into those speakers, I'd just like to introduce my friend, my buddy, and one of our local foot and ankle specialists, Cesc Malagalada, PhD, incredibly bright guy, uber foot and ankle, and he's the guy I'd want fixing my hallux valgus, or sorting out my hind foot when it all wears out later on. So Cesc, thank you so much for coming in. Cesc and I are going to sort of moderate this. Cesc is, as you know, as you'll all know, I'm just a jobbing trauma orthopod. Cesc is the real deal. So we're going to be between us. We're going to try and get some sense out of the speakers and try and get some take-home messages. Cesc, just to kick us off, I feel like, ankle fracture is a good example, but it goes right the way through the foot and ankle scene, through pilons, right through Lis Franc and all the rest of it. Mm-hmm. And calc fractures. I feel like foot and ankle trauma has really changed in terms of who deals with it, who is delivering the science behind it. I remember when I was a trainee, it's not that long ago, maybe it's quite a long time, but I think it's changed now. It used to be one of those things that registrars talk to registrars. It was passed down knowledge how to fix an ankle fracture. And I feel that over the last 5 years or so, the BOFAS crew have really taken on the science behind it and sort of brought it back inside. Is that fair, would you say?
I think so. Indeed, I think there has been significant changes in the foot and ankle practice in these recent years. And in the field of foot and ankle trauma, I do see that shift you're talking about towards the domain of foot and ankle guys. And that's simply because we are seeing this joint all of our working time. And let me tell you something that could exemplify this shift. And if you look back in time at something we were all familiar with, like the Weber classification for ankle fractures, Weber was an AO guy, the quintessential trauma guy who also published on hip fractures and non-unions or other topics. Nowadays, we have the Mason classification, or coming from Liverpool by Lyndon, who's a foot and ankle guide to the core. And this, I think, is a reflection of this shift as we come to understand the complex biomechanics in the ankle and the foot. But if anything, that will only help speed up the development and progress, in that there are more people interested, and it's only good and positive.
Great.
So, well, thanks, Pete, for the introduction. I'm delighted to be here, and especially when taking the place of your usual partner in crime, Kash, right? Who no doubt he's watching, even though it's clashing with the Liverpool game, but I'm sure he's watching, and he'll be paying attention to ankles now. So we might well start up. First up, it's Jit Mangwani, who will tell us about the medial malleolus. So all yours, Jit.
Thanks very much, Cesc, and thank you, Pete, and Kash as well for the invite. Are you guys able to see the screen?
The screen's not shared yet. We can see you.
Yeah. Okay. So how's that looking now?
That's perfect. We can see that.
Great stuff. Great. Thank you. So we'll get started with medial malleolus and deltoid ligament and ankle fractures. I'm Jit Mangwani, work in Leicester, foot and ankle by trade. No major sort of disclosures to declare, particularly in relation to this talk. And so when Kash texted me, I sort of started thinking about where to start, because normally people would ask you to do, can you talk about ankle fractures, or can you talk about pilon fractures or Lis Franc? So, you got quite a lot to sort of, cover in that talk, but this was more specific. He said, I want you to just focus on medial side, and the medial side meaning, malleolus fractures and also the ligament injuries. And then, I sort of clarified with him, are we talking about acute injuries only? So he said, yeah, we're talking about acute injuries in relation to ankle fractures. So are there any changes that we've seen in the last few years? And Pete and Cesc already pointed out there have been some, changes in understanding and the concepts of, dealing with these fractures, and why we're doing something slightly different to what we used to do 20 years ago. So let's get started. So I, like most of you in COVID time, did something different. So I enrolled myself into the WhatsApp University. Like most of us spend most of the time doing that. And in that university, I did a purposive sampling. I don't know whether you guys are aware of that, but I'm quite happy to take that in a Q&A session. So essentially, it gives you some sort of qualitative assessment of what other people are thinking about that particular problem based on some cases that are being discussed. So I found that there were still quite a lot of questions, in spite of the medial side, anatomy being defined and the deltoid ligament being defined for some years now. There was a lot of questions. And also, when I spoke to trainees in our region, I figured out that these lot are demanding. So, they want to know about everything. They want to know about the medial side. So it was encouraging in one sense, which meant, I had to do a bit more work than I thought, well, I'll just put it up and talk about it. So we also looked at some cases, and the good, an ankle look like that. I'm sure people who are logged in and listening to this, you would agree this is the well-reduced ankle, stable, good to go for early mobilization, and pretty much, guaranteed a good outcome. Then we started looking through these cases through the WhatsApp, and they don't look like the one I just showed you on the previous slide. There's a lot of cases like that that are being discussed in various forums, and I've got permission to share these. So and that is not great, because we're still getting things wrong here. We're not understanding some basic principles, and hence why after the talks today, hopefully we'll clarify some of these so that we don't see many of that. And it gets really ugly sometimes, because you look at this ankle being redone, and after redone, not very surprisingly, I'm sorry if this disturbs your sleep tonight, But certainly these are the outcomes that are not acceptable in this day and age, and we must do better, and we must pay attention to what we're trying to achieve when we're fixing these ankles. So the advice on the medial malleolus and the medial side has been like this.
Go to work, don't take public transport, go to work, don't go to work, stay indoors.
So the advice has been, when I was a trainee, the advice was look at the medial side, don't look at the medial side, reduce it, well, reduce it, fix it, particularly the deltoid, just stay alert. And that's not going to give you the answer to what you do intraoperatively. So let's try and sort of, go beyond that. So the themes that we're going to discuss in the next 10 minutes or so are a bit of the work on the deltoid ligament, particularly a bit of understanding the anatomy and where it fits into the clinical practice, and the role of medial side in general in the ankle fractures. Clarifying the 4As and the 4Bs. The 4A and 4B in the supination external rotation injuries have come up in the last few years. They didn't exist when I was training, certainly. And I think we need to understand what it means by a 4A or a 4B SCR injury. And some controversy on, not so much on the isolated medial malleolar fractures, but more of whether you could get away with selective fixation of the lateral side and leave the medial side alone. And a few tips and pearls that I have learned on the way from my experience and others' experience that has been shared with me. So I'm not going to waste your time on the bony anatomy. I think bony anatomy, we're orthopedic surgeons, we've understood it reasonably well. But the ligament, particularly on the medial side, it's worth paying a bit of attention to. And superficial and deep deltoid are the two bits of the deltoid that we need to pay attention to. The superficial has 3 bands, as you can see on that picture here. And one goes to the navicular, one to the calcaneum, and the superficial tibio-talar ligament, which is the main sort of bit to it. The deep deltoid, however, is the anterior bit and the posterior bit. And why we're sort of looking more closely at it is there's some function and there's some biomechanics that's associated, particularly with the posterior tibio-talar ligament. And the posterior tibio-talar ligament is the strongest bit in the deltoid. And when you put the foot plantigrade, it leads to tightening of that particular structure and almost pulls the talus into the mortise. And we'll see 1 or 2 examples of those on weight-bearing x-rays. And you can see the MR images at the bottom end with the PTTL in them. So we went to the lab to see whether this was all true, whether the anatomists were just fooling us. And they're not fooling us at all. Actually, it is very true. And this is the deep deltoid ligament posterior part of it. So it attaches to the posterior colliculus and it comes down to the talus there. So again, I'm not going to bore you with the classifications because these are covered, extensively in teaching everywhere. But just to understand the SCR bit and the stable and the unstable bit of the SCR, it's just important to understand where the mechanism comes from. And, I'm just going to focus on the SCR bit. Obviously, Largensen has two things to the classification, essentially where the foot is at the time of injury and where the direction of force or the injury is. And it is by far the commonest type of injury we see in our practice. And a lot of these, as you can see on the screen, stage 1, 2, and 3, tend to be stable. It is when the medial malleolus fracture happens or the deltoid ligament ruptures is when the injury really becomes unstable. And if the medial malleolar fracture happens, then, as part of the SCR4, you're pretty sure that this is an unstable injury. And, how you deal with it, we will come to that in a bit. But when the deltoid ruptures, does it rupture fully so that you have an SCR4, or does it rupture partially, which is where the SCR4A and 4B come into it? So let's understand what the talar shift is. The talar shift is pretty simple to understand. The talus is moving laterally out of the mortise and the medial clear space increases. For me, I think that is subjective when I look at the x-rays because, 4 millimeter on a non-calibrated x-ray is neither here nor there. For me, I think the left side image, shows a lot more and tells me a lot more, that the ankle should look congruent throughout and the Shenton line should be maintained. And that is the key here rather than just the talar shift. And what causes that talar shift? So we looked at the deep part of the deltoid ligament, which is the PTTL. So either the medial mal breaks or we have a deep injury to the posterior tibiotalar ligament. And how do you diagnose? If you're a trainee and you're listening to us, when I was growing up in orthopedics in early 2000s, we were all told just feel the medial side, and if it's not tender, it's usually nothing wrong on the medial side, and you're fine. There's no medial injury there. But I think over the years, people have looked at it more carefully and found in various studies, and literature is replete with that, to say none of the medial signs are really predictive of a definite injury, or even if there is an injury, whether it's a complete injury to the deltoid or an incomplete injury. And that is important to understand as a concept, because that has a bearing on whether you would treat certain fractures non-operatively, which were actually being treated operatively previously. So why are we bothering about it? Because back in the mid-70s, there was this paper that 1 millimeter talar shift led to 42% decrease in the tibiotalar contact surface, obviously leading to early degenerative changes is the underlying issue with this. And why we're interested as a clinician, this is a lady who thought she just had sprained her ankle and kept walking on it. And only 3 months down the line, you can see the lateral tibial platform is starting to show degenerative changes, and this injury has been unstable and she's been walking on it. So these injuries, when they're unstable, they need to be stabilized. So let's go to this, typical sort of X-ray that you see from the ED, and on a standard plain radiograph. Is there a talar shift? Is there not a talar shift? If you gave it to 5 trainees, they will all come up with slightly different answers, because yes, you can see a little bit of clear medial clear space being slightly widened compared to the superlateral side. It isn't hugely convincing. So we went through the phase of how to assess stability, and in 2010 or before that, there was a lot of emphasis on gravity stress views. We went through good 5-7 years of doing those, and probably overestimating the amount of injury on the medial side, and overestimating talar shift. So if you look at this gravity stress view, clearly you would look at it and say that's an unstable injury, clearly needs something doing to it. And you get the patient standing, suddenly everything looks normal. And that's where the PTTL is sitting essentially. So when you're getting them to weight bear in a plantigrade position, even outside of the cast or anything, suddenly your ankle starts to look congruent. And that's an important concept to take home essentially. So there's been a complete change in terms of the gravity stress views of falling out of favor in the last 10 years, and lots of units have gone down the route to doing weight-bearing radiographs. There's still people not doing enough weight-bearing radiographs and treating some of those injuries that are deemed to be unstable to start with, which are potentially stable by doing an operation. The standing CT, these are a couple of slides shared by Matt Solon, one of my friends and colleagues, and he's basically demonstrating the same thing. If you had standing CT, you could do both sides in one sitting and demonstrate that there's no shift of the talus with that sort of injury. Now, when we look at these, even with an avulsion fracture, which is equivalent of a superficial deltoid injury, some of these tend to be stable. So it's worth doing a standing radiograph on this patient, usually around a week when they are reasonably comfortable, to see whether there is stability in that fracture and they can be treated non-operatively. So we, last year, got into the Kiel University to do a bit of an experiment based on that sort of 4A, 4B, and seeing whether the concept really exists and it is borne out in the biomechanical environment. And if you look at this, This is where PTTL is intact, but you've got SER3 injury, and we're doing axial and torsional loading, and this ankle is not going anywhere. So clearly, that's working. But as soon as we take the PTTL off and look at this ankle and do the axial and torsional loading, that ankle is frankly unstable, and something needs to be done about it. So I think that sort of really supports what we've been thinking in a biomechanical environment too. And again, in this video, it will show exactly the same thing. But when we go to the fixation, the interesting thing that we notice is that once you've stabilized the lateral side, if you did a stress view or a stress to the talus and eversion, you realize that talus is tilting, it's not shifting. If you look at the mortise, it doesn't move, but that talus is tilting. And that's a phenomenon that's underreported and not recognized enough. And we'll come to that in a bit. So what are the implications on classification? So the 4 is now 4A, the stable, unstable fracture, the one that can be made stable from an unstable by weight bearing. And the 4B is the truly unstable fracture, which is where we come into whether we fix it or how we manage that. And we'll go through that in a minute. And the implications on management are pretty simple, because your SER2 on day 1 should be in a boot and weight bearing fully. And an SER4, if you want to, a 4A, where there's a partial tear, you can certainly treat them in a weight bearing cast up to 6 weeks, and maybe x-ray them at week 1 to make sure they're not moved from where you thought they were. But the B is where I would do ORIF in most of those cases. So if you haven't had a chance to read this, Anthony Seclario did a review for eFort, and I think it's worth a read. It simplifies things, and one can understand 4A, 4B concept pretty well. Moving on to the isolated medial malleolar fractures. If the medial malleolus fracture is isolated, the first thing you should ask yourself, is it truly isolated medial malleolar or a ligamentous injury, or is this part of a Maisonneuve type injury? And I think there was a case, for those of you who had looked at the case, it was a great example of that. So first thing is making sure you are dealing with an isolated medial side injury, whether it's ligamentous or bony, usually bony in that case. And the isolated medial malleolar fractures are about 7% of the total population of the ankle fractures. And they can be treated non-operatively majority of the times, because there is enough literature out there to support non-operative treatment. So looking at the medial side fractures, there's obviously a classification, because most orthopedic books or literature will have some classification attached to it. For me, I don't find it particularly useful. What I find it useful is if there's a little avulsion fracture, which is obviously a superficial deltoid injury, that doesn't require fixation as part of your treatment. And if there is a supination adduction type injury, which is the D one, there's a completely different mechanism here. It's a shear, and it needs to be dealt with in that manner. So this is something that has been going on, I think, from Scotland, from Edinburgh unit for some time. I don't think the results are out there, and they're trying to selectively fix the lateral side and leave the medial side as long as medial side is reduced on table, and randomize them into fixation versus no fixation. I don't think the results are out there. There was another study on similar lines from Norway with much smaller numbers, which was underpowered, and they didn't show any difference. So going on to the last bit, which is some tips and tricks when you are fixing these. The first bit is, think who's attached to this injury. I think for anything we're doing, we must take into account who is the patient attached to this injury, what are their comorbidities, what is their mobility status, or how are they going to be best served from what I'm doing, because do no harm is the main thing with anything we're doing. So bearing that in mind is always something that I would do. And look at this, sometimes the size of the patient. For the eagle-eyed amongst you would notice that I've actually put 2 tables side by side to deal with this particular patient's injury. So how are you going to approach and what are you going to do in that situation is important. Always position patient so that you're comfortable doing what you want to do. Your radiographer halfway through an ankle, which is, you're doing a trimalleolar fracture and coming to the medial malleolus last. It's no fun when the radiographer can't give you the view you want. So make sure that you're happy with it and they're happy with it. With regards to exposure, there are a variety of exposures described for medial side. The key here is to be mindful of that saphenous vein and the nerve, because your X-rays look beautiful sometimes. The patient's still not happy because the nerve's been cut and they've got a little neuroma there and it's painful because of that. The percutaneous one is popularized for when the soft tissues are compromised. So, making sure you getting the right exposure and using the right thing to do it. So with regards to reduction, when you're using the clamp, don't be overzealous, particularly in elderly folks where, a lot of the time the medial malleolus just crumbles because of the hefty reduction force that is used. Don't over tighten your screws because it malreduces your medial column as a result of that. And it's not just the AP, you've got to focus on the lateral side, because if the lateral side is not reduced, then you're malreducing from day one and the outcome will be adverse. It's not just the medial side. The medial side is dependent on what you've done on the lateral side. So if there is a malreduction of the fibula and the syndesmosis, like in this case in a young person, the medial side, I can bet my life on it, it is not going to reduce whatever you do to it. Even if you did a ligament repair acutely, that ankle is not going to do well. There's external rotation in that fibula, and there is syndesmosis issue there. So that needs to be addressed, and that makes life very challenging for a revision operation to be done and to achieve a good outcome. So day one was easy. 2 months down the line, it's not so easy. So get it right first time. We're doing it for everything, and the ankles are no different. 3 simple things that you can look for: the dime sign or the O sign. Look at the fibular length. Look at the orientation of the fibula. Look at the syndesmosis overlap and the medial clear space. And all these three things, if you're constantly watching when you're operating, I can guarantee you your malreduction rate is going to go down dramatically, and it will improve your patient's outcome. So a couple of controversies. What do you use to fix on the medial side? Do you use a tension bend? Do you use a screw? In my hands, I'm more into the screws. I don't do tension bends unless it's absolutely necessary. But when you decided to do a particular implant, do it well. That's the key here. The length, you might be a budding hand surgeon there, but the screws exist longer than those, the one on the left side that you can see here. So know your kit, know what length you're going to use. The optimal length in most biomechanical studies is around 40 to 45. Whether you use partially threaded or fully threaded, it doesn't matter really, I think, although fully threaded have been shown to be biomechanically more sort of in favor. And whether you use bicortical in osteoporotic bone, and that's a consideration you must give. And the safe zone of trajectory, this is I've taken from Tim White's paper in the BJJ last year. And the green that you can see on the left image is essentially your green area to go in. And beyond the red, you're looking at tip post being in that area. If tip post is there and you're so posterior, you're going to hurt the tip post, or you're going to injure it. And not just with that entry point, your trajectory could be wrong and be touching the tip post or damaging it. So I think be mindful when you're shooting. It should be in line with your anterior tibia when you're shooting your medial screws. If it's a supination adduction type injury, be mindful of the plafond injury and reduce it well, and then hold it. Whether you hold it with screws or plate, there's no problem with that. You could use a plate, but I think don't forget that there's an impaction injury on the medial column there. So rehab them early. Don't do orthopedic units of 6 weeks in a cast and non-weight bearing. Those days are gone and should be gone completely soon. Think early weight bearing and think functional rehab, and Air is finished. Air is where ankle injury rehabilitation looked at 2 weeks, beyond 2 weeks, having early rehabilitation of the ankle and early weight bearing if possible. And wax is particularly looking at the weight bearing in ankle fractures, which is undergoing and will be recruiting more centers soon. But audit your practice, and I think there's nothing that ruins your results like your own follow-up, as they say sometimes, but I think you learn a lot in the process, and audit changes practice. Definitely in our unit, some 10 years ago, there was a lot of malreduction, and the ankles were not treated as well as they are now. Acknowledgements to my colleagues. You know, we bounce ideas of each other. Lyndon and Hiro included in that. They're great guys, and you'll be listening to them soon. A big thank you, and any questions I'll be happy to take it later.
That's awesome, Jit. Thank you so much. That's terrific. I mean, we'll get Cesc to bring out some of the Q&A in a second, but I love that idea of the PTTL. Am I still there? I love the idea of the PTTL snugging the talus in when you come up into, you talk about plantigrade, but that's basically bringing up into dorsiflexion at 90 degrees. But only there does it become tight, and therefore it's only when it's there that you know whether it's stable or not, whether that's intact or not, and that's why when you're slightly plantar flexed, which when I think there's gravity stress views you showed when people were doing those, that it wasn't brought up. It had been, it's a little bit plantar flexed, and so obviously it drops down because it would do, but that doesn't mean it's not stable. That's a beautiful demonstration. Cesc, can I hand over to you for some of the Q&A?
Sure. So there are some questions. Just to remind everyone that the questions need to be posted on the Q&A section, not the general chat, because that we were not going to go through them otherwise. But one question that comes up, which I think it's something that it's recurrent, is there a situation when you attack the medial side first or the lateral side first?
That's a great question, and I knew somebody would ask that. So traditional teaching, as you know and we know, we all did lateral side first, and sometimes malreduced. If you look at the malreduction rate of a fibula and syndesmosis, it can range from 30 to 50% in some studies. So by that time, it's too late. You fixed quite a lot of stuff there, and as I showed in one of my X-ray pictures there, that you've got very little to do with the medial side being at fault. So the times I would do the medial side first is I'm a firm believer and screen my ankles on table. So if the medial side is not closing right from the beginning and there's some mischief going on, I have a very low threshold of opening the medial side and doing something about it then and there. The other times, and interestingly, in the COVID period, we had a selection of patients where to expedite and get patients out of the hospital and also just do minimal surgery, we've done medial side when the lateral side is not comminuted. It's in a stable sort of Weber B type fracture, which is like a 4B, which I showed in the picture. So if you did the medial sides, the lateral side becomes completely stable, and you can treat them in a plaster cast after that. So those are the times I think you would certainly think of medial side first. Right.
So basically, when you are anticipating some sort of trouble to fix the medial marker, sometimes it can be the most difficult one to fix, right? Much more than the lateral one. Agreed. Yeah. Or even those supination adduction fractures where you see a vertical shear line, right? Yeah. Those sometimes have some articular depression and they can be difficult to fix. So addressing that first might be.
Yeah, I mean, supination adduction is a medial injury for me.
Yeah.
There's very little to do on the lateral side. So I think that's the time. I wouldn't even, all I would do is probably have a cursory look on the lateral side, but the lateral side is not a misbehavior there. I think the platform needs to be reconstructed and you need to either buttress or screws, whatever you are happy with, get the anatomy right and hold it horizontal. The picture I showed in the bad ones is when people get the usual sort of, it's a medial malleolar fracture, it needs 2 screws. It doesn't need 2 screws. It is completely different to what we do for medial malleolar screws. It needs to be at right angle to the fracture where it is, and needs to be reconstruction of the platform. And if it means opening up and seeing it accurately, you need to do that. And if it means putting a little bit of bone graft to support the articular fragment, the die punch that's gone up, then it needs to be done then and there.
Guys, I'm going to stop you there if that's right. Just we probably ought to move on. If you could pick up some of those Q&As, you can respond to them while Lyndon's speaking.
Sure.
Cesc, over to you.
So shall we have time for a few more Q&As now, or
I'd probably move on.
Let's move on. Let's move on then to Lyndon Mason, who's going to tell us all about the posterior malleolus. So over to you, Lyndon.
Okay, here we go. Ooh. Sorry, I don't know why that's doing that. Stop share. Try again. Great. Everyone can see it? Is that all right? Yep.
Working perfectly.
Thank you very much, Mike. I sort of want some feedback. Great. Okay. First of all, thank you very, very much for OrthoHub for inviting me on for this. I'll try my best to stay in my time. I could talk on this for hours. As anyone who knows me, it is my hobby horse. There are some disclosures. So I am a consultant with Stryker and a consultant on implant design with Ortho Solutions that do impact on this. And I'd like to acknowledge all my colleagues, juniors and anatomists that have worked on this with me. It's been a bit of a labor of love for me for the last 5 years. And these people have certainly been on the journey with me. So this is where I start. So people who don't know, Susie Dent is in the library corner of Countdown. I follow her on Twitter as I am an etymology geek. And she posted this back in May, which I truly believe sums up orthopedics in a nutshell. Ipsedixism is the dogmatic assertion that something is true because somewhere said it without offering any sort of evidence. So I realize the irony of me talking and trying to give this, but I'll try and give some evidence on what I are going to go through. And this is really the biggest myth in foot and ankle fractures, in my opinion, is that we only fix greater than a third. And that has been reduced to 25% over the last 20 years, but it's still, if you want to go 30% or 25%, we only fix greater than a third. So we can track this back to Nelson and Jensen's paper back in 1940, so 80 years ago, where they split them up into minimal if it was less than a third and classical if it was greater than a third. And they said that if it was offset, it didn't really matter. It didn't preclude to a good result. But as you can see by the bit below, which I've highlighted, this wasn't truly normal management to what we would do today. These were usually treated in an above knee cast with a knee in flex position. And I apologize for swearing, but what the fuck is 30%? So this is a lateral x-ray. So it depends on how good your radiographers are at giving you a good lateral x-ray. This is an example. And for me, I think that's about 20–25%. If you go to the CT scan, you can see the x-ray is just shooting straight through. And this is actually a rim fracture. It's got nothing to do with the plafond itself. And it's a avulsion fracture. This, not that much different, 20–25%. But this is actually the entire posterior plafond. Very different to the initial injury. Again, similar picture. This one is the lateral plafond, a very large injury, much bigger than what you can see on the x-ray. This one looks pretty big, but actually this is a 2-part fracture. Very different to the last injury. This one, you can, for those with eye of faith, you can see something going on there. As you can see here, you can see this is the entire posterior plafond. And these posterior medial injuries are really not picked up on lateral radiographs because the shape of the tibia hides the medial side. So how reliable is a plain radiograph? Well, there's 8 papers now in the literature showing all the same that it is rubbish for looking at the posterior aspect of the tibia, 22%. So 1 in 5, you'll have accuracy. So you are going blind really of treating these injuries. And CT change surgical management in the majority of cases, and posterior medial fractures are really not visualized. So for a statement, us in Liverpool, we CT all posterior malleolar fractures, even them little flakes, because that can be a very large posterior medial fracture. Okay, the next argument is, well, biomechanical studies said 30%. 30% of what? So what were they looking at? Were they looking at the apple, orange, or pear? And these are very, very different injuries. And posterior malleolar is an umbrella term that surrounds all these. So if you look at the biomechanics of the ankle really should only rotate in the around the y-axis. Okay, there is small amount of movement in other aspects, but really the most function is a rotation around the y-axis. There's certain aspects, as Jit has already been through a lot of these, that stops it moving in the other directions. So the posterior malleolar actually comes up twice. It comes up to stop the axis, x-axis translation, so posterior translation, and it also stops the z-axis rotation. Okay, so rotation around the ankle. We published this in 2017. It seemed to have some traction now. It's more cited, in the top 5 cited, most cited paper in FAI over the last 3 years, where we described it really by mechanism. So you have a PITFL avulsion, a rotational pilon, and an axial loaded pilon. Now, there was classifications before us or around the same time as us. So Haraguchi, a lot of people know Bartnek, and really you can actually put them all into the same bit. But if you take anything away from this, is that look at the mechanism. So you have PITFL avulsions, rotational pilons, which there's 2 types, minor and major, and an axial loaded pilon. The PITFL avulsion, so this animation, we've taken out the fibula to show. So the foot is in equinus, and on that equinus position, it's unloaded, and as you rotate, you peel off your PITFL. So this is the avulsion injury, the type 1s. Your type 2s are either minor or major, and this is a planted foot, such like studs in the grass in a rugby player. And you can see here, as the talus rotates, it hits the posterior overhang of the posterior malleolus. It hits that one off first, and as it continues to rotate, it can hit off your posterior medial side as well. That's why it's 2 elements to it, as you can see here. And you can see the rotational, as I show now. And so if you imagine that force applied, fracture will occur 45 degrees to that. This is your angle to 45 degrees of a rotational force, as you can see. So your type 3 is your true posterior pilon. I think everyone is pretty happy with this. You get a foot in a plantar flex position, and an axial load, and then it takes off your posterior tibia. So if you talk about classifications about percentage, your type 1s are definitely below 25%. Your type 3s are definitely over 25%, and your type 2As and Bs are somewhere in the middle. That's the reason why I don't think percentages should ever be used for the posterior malleolar anymore. So these are the 3 biomechanical studies that was produced before this year, which you can see that you have 2 anatomical papers and 1 3D computer modeling. The problem with this is it only looked at your posterior translation of your talus. So they only looked at your greater than 30%. So when they tell you that it doesn't matter, as long as it's less than 30%, it's okay, they only looked at it on the translation. This paper by Haraguchi, as of the Haraguchi classification, was published this year in OTA. They actually only done pronation, which only accounts for a small amount of these injuries, and they had some that had your type 1 injuries and some that you had your type 2s, but it shows that these are rotational injuries. We published this back in 2019, looking at the posterior medial fragment, and noted quite specifically that if you had a pronation type injury, then this posterior medial side was avulsed. But if you had a supination type injury, this is where you had this classical rotational injury. So the results prior to 2017 were poor. So if you had a posterior malleolar fracture, you done badly, and that was it. And so no matter how you treat them, they just done badly. Their functional scores were always poor. Size was never a factor in neither of these two systematic reviews that was produced on this. But they both noted that if you had an articular step, regardless of the size, you had a poorer result. So since 2017, we have pushed forward. So in Liverpool, this is our algorithm. So based on our classification system, number one gets syndesmotic fixation, and then all the others gets open reduction to fixation by different approaches. And I can go through this later in the Q&A or do another talk on the approaches and why we choose them. So type 1, this is a very typical non-profound injury. And this, you pick a screw or tightrope, whatever your poison is, and you get a syndesmotic fixation. Your type 2A, rotational pilon minor. It's a very type. This is with a major nerve type of injury. And so if we, I think we'll talk about this in the Q&As later, but if you're trying to achieve length, you can achieve length by fixing the posterior malleolar. And then all you need to do is actually control rotation. That can be done with a tightrope, as you can see. And your type 2Bs, the rotational pilon majors, and the problem you have with that is that if you fix the posterolateral side first, you spit out your posteromedial side. Now this is an example of this. As you can see, the fibula is out of its position, but you can see your posterolateral, posteromedial fragments. And when this is fixed, you can see this double shadow on the medial side. And this is what happens. You get a double shadow because it spits it out and doesn't allow you to reduce it. This is one pre-op. You see very similar type of picture. Fix the posteromedial side first. And this is the posterolateral side, which is still off on the back. And then you fix the posterolateral side afterwards. And then obviously this is, because you've controlled the length, this is then a tightrope to control rotation. Your type 3 is a true posterior pilon. This is probably the easiest ones, such as this. These can be easily fixed with in my hands, a buttress plate. Then I lock the buttress plate with a candidate screw of some type to get some lag across the joint. There's another example in an osteoporotic patient. Again, similar type 3, fixed as such, exactly as before. So did this do any good to our patients? That was what I was asked initially by all my colleagues in Liverpool. Why are you fixing these? Are they doing any good? Now we found that our initial paper with Leicester, with JIT, anyone who had a posterior malleolar fracture had an OMAS score around about 50 odd. Okay, they all done badly. It doesn't matter if you fixed them well, if they were reduced nicely, they all done badly. If you didn't, if they was classically not fixed from the back. Since we have moved on to this algorithm, our actual functional scores have improved. So the current study was published in JIBGS last year, showed our OMAS score came up to the level of what we expect for unimalleolar levels. And this was throughout the classifications. It wasn't just that we had them in the type 1s, we had them through to the type 3s. But we're not alone. So there's now 8 papers since 2017 that all show that fragment-specific fixation have brought your results back to the level of bimalleolar or even unimalleolar levels. And these are level 2 to 4 studies. What about the syndesmosis? So it's going back to our first paper in 2017. The type 1s had 100% syndesmotic injury. So that's why we evoke that all of them get syndesmotic fixation. Some of them won't be obviously unstable in the normal external rotation test or your cotton test, whatever you use. You have to do an internal rotation test to show it. But in your type 2s and type 3s, it doesn't mean that they're going to have syndesmotic injury because these are pilons. So for example, this is a paper that we've done on the insertion of the posterior inferior tibial ligament that shows it's a very, very large ligament. It's not just a small area, it actually encompasses the entire back of the tibia. Note as well the intermalleolar ligament. This is where you get the avulsions of the small bit. These were our anatomical pictures, not as good as Cesk's ones. If you want to look at good anatomical pictures, look up Cesc on PubMed. So when we compared this to our actual fracture size, you can see that your PITFL is much larger than any of even your type 2Bs. And therefore, if you get a bony injury, it doesn't mean the ligament is peeled off. However, if you do have a syndesmotic instability and you fix the posterior malleolar, these 5 papers have shown that sometimes you don't need then to do a syndesmotic stabilization with a screw or tightrope, and the stability of the posterior malleolus fixation was much, much greater. So why do you not fix them from front to back? Okay, so this is a case that came from elsewhere for revision under my care, where you can see it's hit that and pushed it off. It makes no biomechanical sense to do so. Also, you can get soft tissue entrapment. So this is the case that we had where tibialis posterior is stuck within the fracture site. So if you do in front to back, you're not going to be able to fetch this. There are 3 papers in the literature looking specifically at this. Level 1, 2, and 4 studies. So there's a level 1 study in there, showed significant improvement in anatomical reduction and functional outcomes with the direct approach, so the posterior approach. In the long term, there's 1 current paper, follow-up of 6.3 years, so a midterm study, level 2 study, and reduction was key. And they put it down to 1 millimeter. So if there's a 1 millimeter step, that will give you a worse outcome. Now, articular step off is an independent indicator for both functional outcome and arthritis. So to conclude, so size does not matter, percentage should never be talked of again. CT, all posterior malleolus fractures if possible. Fracture mechanism guides management. They're developing evidence to fix them fragment specific, and going from the back is definitely better than going from the front. Okay. Pete, you coming back in?
Yeah, that's brilliant, mate. Yeah, it's great job, great job. I can't believe it. You did 78 slides there, and you smashed through in the time. So well done. You got us back on track there. But before I hand over to Cesc, can I just hit you? Just tell me how you fix a pure ligamentous syndesmosis. So it's a pure out and out, like, you know, syndesmotic injury, a Weber C. Maybe it's got a high fibula, but there's no other fractures around the ankle. Pure ligamentous. How do you do that?
So for me, the first thing is that you've got to achieve fibular length. So if you can achieve fibular length by pulling on it, that's fine. But then when you fix it to the tibia, you can't have something that has no axial stability. So bringing a major nerve down and putting 2 tightropes in or 1 tightrope in is not a great option because it gives you rotational control, but it doesn't give you axial control.
Got it.
If you fix the fibular length, so you either fix the fibula, so with a plate and screws, whatever your poison is, then a suture button makes sense because then you get rotational control. So the great thing about the posterior malleolus fractures, if you got one of those, you can achieve length by fixing that. Yeah. And that will bring your fibula down. And then you can just put a syndesmotic fixation with the suture button. In regards to the medial side, as obviously just been through that, but we can go through that later on if you want. Yeah.
But in terms of like how you actually make sure that you got it right, because it's so easy to like jam it together. Yeah, it looks about right, and then maybe it is, maybe it isn't. You know, we know that these often get reduced, don't we?
So I've been I went through a curve of scoping them all, and I must say, in my hands, it didn't make a difference. I must say, as soon as you put the clamp on, your view disappeared in my hands. Yeah. People are much better scopers out there than I am that would probably do that well. But what I do is make sure your incision for it is on the anterior third of the fibula, so you can get over the front of it and make sure you got a reduction in the incisura.
Yeah. And so you're looking at those. Well, on fellowship, they talked about the three hills. You know, they're kind of like, you know, the talus, the tibia, and the fibula all kind of lined up next to each other, like so.
You don't need to go down as far as the talus. You're about 2 centimeters more proximal to that. What you're looking at is your incisura. So AITFL is coming over the top, and obviously, if you've got a full disruption, your AITFL will be wispy and gone. Will allow you access to the anterior incisura. Coming around the back, however, your posterior incisura is not approachable. And the reason for that is that your perineal artery comes straight down the middle of it. And then you get a perineal perforator just above the incisura, which comes through to the anterior aspect. So you can't mobilize it. Yeah. So if you're going to approach the incisura, it has to be from the front.
Cesc, over to you, mate. Cesc, microphone, old boy.
Oh, sorry. There we go. Let me ask first, Lyndon, there's a question here about position and approach for both the posterior medial and posterior lateral fragment. Can you explain that? Sorry, that's gone off. Now, there are a few questions that are referring to the FAME trial. That's comparing unstable fractures with either a cast or if, right?
Yeah.
And that was always going to come. And Xavier's been very active, who's leading the trial in the group. Now, do we think, and that's open to all members of the panel, is there any evidence that a well-reduced ankle held in a cast would benefit from ORID?
So can I just so I think the initial statement has to be that you have a anatomically reduced ankle, and you're either going to treat it conservatively with a plaster cast or operatively with surgery.
Correct.
So it has to be reduced. So if you can achieve reduction with your plaster, then I don't need to fix. So the only reason I'm fixing it is that, number one, I can't get a reduction, or number two, I can't hold that reduction.
Right.
Yeah, but otherwise, if you can do without surgery, then perfect. A person doesn't have the insult of incisions with that, but you have to be able to reduce it. So if you can reduce it, then obviously it falls within the FAME trial, of course it does. But it has to be.
Okay. What's your take on that, Jit?
So I would agree with Lyndon and probably expand a little bit more on what we don't know is how many of these ankles reduce anatomically. The unstable we're talking about, the trimals that Lyndon has shown and the bimals that I've shown. Can you reduce them anatomically, and what are you using as a criteria for your anatomical reduction? Because our thresholds are very different in what we do. So some people are absolutely pernickety about 1 millimeter of this and 0.5 millimeter of that. For some, if the ankle looks roughly right, that's enough well-reduced ankle. And the other thing is, it's about stability. Can you achieve stability with non-operative measures, such as a close contact cast or a plastic cast of some sort? And the third aspect is the rehabilitation of these. So we've gone from being non-operative, in 70s, 80s, and putting these people in plastic casts for 8 weeks and 12 weeks in those days, with muscle wasting and lack of functional rehab and affecting their outcomes adversely, to then having the TAs and the ankles having a momentum for early rehab, functional rehab, getting back to work, getting back to doing things, and certainly seen, certainly in the TA world, nobody should really put anybody in a plaster cast for 8 weeks, 10 weeks, or whatever it takes for it to heal for non-operatively. So I think you're going to have to take a step back on that. Definitely, you can't weight bear. Don't tell me, if anybody is out there who has got the balls to weight bear an unstable ankle, treated in a close contact cast, even if it looks okay on day one, to say, Mr. So-and-so, you can weight bear on it in a week's time. Challenge me, I'm happy to be challenged.
Can I just wade in there? So what's happening during that week? So you fixed an ankle and you're delighted with the fixation. You think it looks totally awesome. You had good bony bite. You've plated it all. You've herded it all in. You're saying you wait a week before you weight bear them. What's going on in that week? Is that just letting wounds settle down, or? Yeah,
I think that is pretty much what you're looking at, to let the wounds settle down a week, 10 days time, and that's when they're seen in the clinic and seen by a specialist nurse who says, yeah, all good, and good to go. So I think that's what, yes, Vax also would not answer that, whether you day one weight bearing is going to be better or not, but at 2 weeks, certainly we're way better than starting at 6 weeks.
Yeah. Lyndon, you had something to say?
Yeah, so I think we moved on from that, but it was about the weight bearing. So with these, someone's asked on the post-op protocol for postural malfixation. So similarly, I'm chicken. I wait for 2 weeks, just allow my wound to heal. I got no evidence of why I wait for 2 weeks, but I always wait for 2 weeks. Some of my physios have been trying to push me to weight bear day one, but I've always been too chicken. But they weight bear in a boot from 2 weeks. The paper that we published on the posterior in JBJS last year, I actually waited 6 weeks. So they were all 6 week waiters before I weight beared them. I was even more of a chicken then. And I developed. But I find that they, anecdotally, because we haven't fully analysed the current cohort, but they do a lot better when they walk quicker.
Understood.
Good. Great. I think we could move on now. We're going to set aside the ankle and move further down to the foot. I think we've had enough of the ankle now. So we'll talk about an injury that sometimes is a bit unclear or not completely understood, which is the Lis Franc injury. And Hiro will tell us everything about it. So over to you, Hiro.
Thanks, Cesc. Good evening, everyone. So now for something completely different. So before I load up my slides, if you look behind me, you'll notice quite a few old books. Now, what that represents is hundreds of years of orthopedic knowledge. And the reason why I'm passionate about this is that it's a constant reminder of a very human frailty. And that is the unshakable belief that something that's new has always got to be better than what preceded it. Now, the words of the surgeons who wrote these books are a testament to the fact that that is not always true. Now, one of my favorite aphorisms, which was written by a 19th century surgeon, was this: surgery is brighter when operating, but it is brighter when there is no blood and mutilation and yet leads to the patient's recovery. The reason why I love this aphorism so much is because I believe that this defines who we are as surgeons. Yes, we all love operating, but ultimately we care more about what is best for the patient. So it's apt, therefore, that the person who wrote this was Jacques Lisfranc. And he wrote this in 1815, and he was a Napoleonic field surgeon serving on the Russian front. And he described a midfoot dislocation seen in his cavalry officers when they fell from a horse and got their foot trapped in the stirrup. His words are written on the side of the tombstone in Montparnasse in Paris. Now, Jacques Lisfranc was a keen carpenter in his youth, and very much like carpenters have various tools in their toolbox to carry out their work, we too as surgeons must have different skills and tools in our armamentarium in the treatment of a patient with a fracture in order to do the best for them. Now, I believe that there are 5 skills that we need. The first is a deep understanding of the pathoanatomy and the pathomechanics of an injury. Without it, it's a bit like a car mechanic trying to fix a car without understanding how an engine works, or an airline pilot trying to fly a plane without understanding the physics of how a plane flies. Then we need clinical judgment. The judgment to be able to accurately diagnose, to order investigations prudently, and to know when and how to treat a patient. We also need a broad understanding of the evidence base, because we must practice with equipoise, which basically means without bias. Now, experience is important and it's a tool, but we must always be mindful that experience is often colored by what we've always preferred to do, as opposed to what we've observed to be in the best interest of the patients. And then we need technical skills. Technical skills to carry out the procedure that we intended. But probably more important than that is knowing when a procedure is beyond our capabilities. And I believe that the best and greatest surgeons are the ones who have the humility and insight to know this really well. And finally, everything that we do for the patient should not be based upon what we want to do, but it should be directed by what the patient would want us to do. So we must listen to the patient. So in order to help me navigate the management of Lis Franc injuries, I'm going to focus on the clinical judgment side of things, because most of the other stuff you can go on ortho bullets and read up in the book, but clinical judgment is something that is often not written about. So we're going to consider and imagine that we're treating 2 patients who represents the spectrum of Lis Franc injuries. The first is a 29-year-old store manager and she's enjoys going to the gym on a regular basis. She's otherwise fit and well. And she presents to our fracture clinic a week following the injury, having gone over on her foot. Now, the questions that we should be asking, looking at that x-ray, which essentially looks pretty much on normal, are, how can we tell whether this patient has a Lis Franc injury? If she does have an injury, a Lis Franc injury, how do we know whether it's stable or unstable? And this is the core of the management of this patient, because whether it's stable or unstable fundamentally determines what we're going to be advising for this patient in terms of surgical intervention. So unlike other joints like the wrist or ankle, it's very difficult to manage an unstable midfoot in a plaster. So there's really limited scope for non-surgical conservative management of an unstable midfoot injury. But of course, everything that we do, it's not black or white, it's not binary, is it? So if in many instances, we're really not sure whether an injury is stable or unstable. So if that's the case, then what should we do now? And then once we have that information, which patients can we treat non-operatively? The next patient who presents with essentially a foobar foot is a 46-year-old gentleman who presents to A&E. He's a builder, self-employed, and his foot was crushed in a JCB at work. So the questions here are very different. It's not one of diagnosis, but one of limb preservation. So what should we do on an emergency basis if there's severe soft tissue damage or an open fracture? If it's closed, should you try to reduce it? And if so, how? When should fixation be performed? And if we're going to fix it, what's the best fixation method? So even though we've got two patients with totally contrasting histories and injuries, we must not forget the main principles of what we're doing for the patient. So the principles are restoration of the anatomy, a stable foot, which means that not a patient that doesn't develop a collapsed arch, which will cause dysfunction in walking and will cause later onset osteoarthritis. A plantigrade and functional foot, which is maintaining wherever possible the mobility of the midfoot joints. And finally, managing the soft tissues so we don't get a patient with an infection and CRPS and so forth. So probably the most important principle here in terms of determining outcome for the patient is restoration of the anatomy. And the seminal paper from Sanjorzan and Ted Hansen from Seattle clearly shows that anatomic restoration directly correlates with functional outcome. And this has been validated by numerous papers since it was first published. So I'm going to give you 7 helpful tips on how you can manage both of these patients safely with a satisfactory outcome. So let's start with the young lady with normal looking x-ray coming with a suspected Lis Franc injury. So how can we tell if there is a Lis Franc injury? Well, the key learning point is that the standard x-rays which are taken in most A&E departments, which is an AP and an oblique non-weight bearing view, is unsatisfactory. It is not a radiologic diagnosis. Because if you rely on the original radiographs, you will miss 40% of all of these injuries. And the reason why it's missed is because those x-rays are not sensitive enough to pick up subtle displacement. So in the study by Lau, all 1 millimeter displacements and 60% of 2 millimeter displacements were missed on the original films as compared to the CT. So if we can't rely on the original x-rays, then what do we rely on? Well, the first thing is a high index of suspicion, and that starts with the mechanics of how the injury occurred in the first place. So there are 2 ways in which the injury occurs: low energy indirect injuries and high energy direct injuries. So the classic history that's given is a patient with a plantarflex foot that trips over something and rolls over their plantarflex foot, causing a disruption of the second TMTJ dorsal capsule and resulting in subluxation. So that is a low energy injury. Now let's add in a little bit more energy and add in pronation and abduction to the injury. And the classic history there are of sports injuries and of equestrian injuries. So what happens there is that there is a progressive failure of the midfoot ligaments, starting from the medial side, going all the way potentially over to the lateral side. So this is something that we have to be aware of, and it is the pronation effect that's created this injury. So if we look at the high energy injuries, well, the typical history that's usually given is a warehouse worker who's got their foot crushed, or a builder who gets their foot crushed. And the degree of displacement and the degree of bony damage depends purely on the degree and direction of the forces applied to the foot. But there's also the road traffic accidents, which are the commonest form of Lis Franc, serious Lis Franc injuries. And this is as a result of a direct deceleration of the brake pedal pushing up on the midfoot, causing a dislocation. So the mechanism of injury gives us a real insight into what potential for injury there is in terms of both the ligament and also the bone itself. But in the fracture clinic, we've got to take the back slab off. Got to take the back slab off, got to have a look. You know? So let's have a look at the patient's foot. So there's going to be a band of midfoot swelling, which is going to be incredibly tender, more so than a standard ankle sprain. And you're going to see potentially a subtle malalignment. If you look at the picture on the left, the medial side doesn't look right. There's a slight abduction deformity there. So if you look at a patient's foot and it doesn't look right, it's a Lis Franc injury until proven otherwise. Have a look at the plantar side of the patient's foot and look for that plantar ecchymosis that you can see on the right-hand side. That is a pathognomonic clinical sign of a Lis Franc ligament failure. A useful test described by Kaiserman is something called the piano key sign. And what you do there is you basically plantar displace, like a piano key, the head of the second metatarsal down, which stretches the dorsal capsule of the second TMTJ and replicates the pain. So that is a strong indicator of disruption of the Lis Franc joint. Now, you may also have heard of the pronation abduction test proposed by Meissen. Now, I would caution you about doing that in clinic, because that is incredibly painful, and it's actually reserved for the way that you do an EUA under anesthetic. So it's not to be used in clinic, but it is useful in theatre. So the key learning point here is that it's not the original radiographs that gives you the diagnosis. You can virtually chuck them in the bin. It's the history and the clinical findings that gives you the likelihood that you're dealing with a Lis Franc injury, and it is an injury until proven otherwise. So the next question is it stable or unstable? So there we have to understand a little bit about the structure of the Lis Franc ligament. And we're all used to seeing the picture on the left of a ligament that binds the medial cuneiform to the base of the second metatarsal. But the Lis Franc ligament is really a complex, and it's composed of 3 ligaments, starting from the red ligament, which is the dorsal capsular ligament, the blue ligament, Lis Franc ligament, that's interosseous, and the plantar green ligaments, which attaches the medial cuneiform to the base of the second metatarsal and the medial cuneiform to the base of the third metatarsal. So Matt Solon did a cadaveric study looking at the relative strengths of these ligaments and found that the Lis Franc ligament was stronger than the plantar ligaments, and the plantar ligaments are stronger than the dorsal ligaments. So Nunley and Vertulo had a classification system looking at athletic injuries, looking at pure ligamentous Lis Franc injuries. And they've used weight-bearing x-rays and bone scans to identify 3 stages of this injury. And what they discovered was that in stage 1, there was no displacement, and yet there was a Lis Franc injury. So yes, partial or sprains to the Lis Franc ligament can occur. In stage 2, there was a rupture of the Lis Franc ligament, resulting in a 2 to 5 millimeter diastasis. And beyond a 5 millimeter diastasis, this is stage 3, you're starting to now see arch collapse. Now, I'll bring your attention to a paper by Haraguchi, the same Haraguchi from the posterior malleolus fractures, and they noted different patterns of ligamentous injuries. So the classic Lis Franc injury is a transverse one. It comes straight across the base of the second metatarsal. But just occasionally, there is also a longitudinal element in between the cuneiforms. So this is something that you need to be aware of. So the answer to how do we know it's stable is get a weight-bearing view. Weight-bearing views are so important in the management of lower limb injuries, ankle fractures, and foot alike. So comparative weight-bearing views are useful because in comparison views, you can just look at the x-rays at a distance, and our eye is acutely sensitive to picking up asymmetry. And so in this patient, it's an injury to the right foot, and the normal is the left foot. And even at a distance, you can tell that there's something not quite right in the space between the first and second metatarsals. So now we can really start inspecting in detail the AP 30-degree oblique and the lateral weight-bearing x-rays and look at them in detail. So we want to look at each ray in turn, starting from the medial side. So the lateral portion of the medial ray, medial portion of the second ray, do they align together? The intermetatarsal gap, which should measure less than 2 millimeters, the intercuneiform space as well. Then in the oblique view, we can look at the third ray to the lateral cuneiform, the fourth ray to the cuboid, and then also look very carefully at the cuboid to see if there is a cuboid crush fracture. That indicates that the injury has gone all the way to the lateral border of the foot. On the lateral view, we're looking at an unbroken line over the dorsum of the second metatarsal with the intermediate cuneiform and the first metatarsal and the medial cuneiform. And you can look for the structure of the arch by drawing Meary's line. And look carefully in the space between the first and second metatarsal to see if there's a little fleck of bone there, which is called the flex sign, that will be indicative of a ligament, Lis Franc ligament avulsion injury. So the learning here is partial Lis Franc ligament injuries do occur and they are stable, and it's the weight-bearing x-rays that will really help to determine stability. But of course, nothing is as clear as that sometimes, and sometimes it's equivocal. And there are 3 reasons why it might be equivocal. The first and probably commonest reason is that the patient simply can't do it, or you're not happy that the patient has properly weight borne on the x-ray. Now in that situation, then I think it's quite reasonable to take a pragmatic approach. There is no rush. The important thing here is getting the diagnosis right. And so in that situation, absolutely fine to give the patient a boot, encourage them to weight bear as tolerated, but ask them to come back to repeat the x-ray the week after to make sure that we can get proper and accurate weight bearing views. Now, if we're looking at the views and see a subtle displacement like this patient that we saw, then the question really becomes, okay, am I looking at a subtle displacement? And in that situation, the gold standard test is a CT scan. So in this CT scan here, you notice that there is indeed a flex sign. So she does have a Lis Franc injury. And if you look at the second TMTJ, it's not so much that the joint is subluxed as such, but there is almost an angular deformity at the joint here. The third reason why it might be equivocal is you're dealing with a athlete or somebody with very high expectations. And in those kind of situations, I personally feel nervous about this patient in terms of their expectations, but also without really understanding what has happened to the ligament, it's really difficult to give them advice as to when they can get back to competitive sports. And the gold standard to look at the ligament in that situation is an MRI scan. So what Rakin did was to analyze the MRI scans of patients with Lis Franc injuries and determine that the fundamental determinant of stability is the plantar ligament. So if there is a rupture of the plantar Lis Franc ligament complex, then that indicates that the injury is unstable. And you can see here on this MRI scan, there is high-risk signal around the bases of the second and third metatarsals. So the learning point here is that it's important to get the diagnosis right. So let's get proper weight-bearing x-rays, even if it means deferring the investigation until the patient is able to do it. CT is great for picking up very subtle subluxations or displacements. An MRI scan is good for high functional demand patients where you really want to give them a prognosis and advice in terms of their competitive sports activity. So the question really comes to, so who can we treat conservatively? Well, as I said, the bottom line is that unstable midfoot injuries are very difficult to manage in a plaster. So if there's demonstrable instability, then the advice is to treat them surgically. So undisplaced fractures with reliable weight-bearing views or CT are absolutely suitable for conservative management. Now, the real question is what is undisplaced? And if you certainly read up in the books, 2 millimeters has been cited as the undisplaced amount. Now, bearing in mind the original paper by Sanjorzan and Ted Hansen that showed that anatomic restoration directly correlates with outcome. So I don't know whether 2 millimeters is acceptable for a particular patient, but there's an interesting RCT being carried out in Finland at the moment, which they're going to be reporting on next year, which addresses this very question, is what is the definition of undisplaced? Probably the most important thing, though, in terms of non-surgical management of patients is really considering the patient's wishes and also the patient comorbidities and their mobility status. So if you've got a patient who is not particularly mobile, has relatively low expectations or has comorbidities, then even if there is a subtle displacement, what's the harm in treating them non-operatively? Because ultimately, if it all goes pear-shaped, then the treatment is a midfoot fusion. So it's an operation that you're proposing at the beginning or an operation at the end. And as long as you have a constructive discussion with the patient about the potential consequences of conservative management, then it's absolutely fine to go down those lines. So this has to be a really patient-centric approach. So partial ligament injuries, as verified on the MRI scan, even in high-level athletes, absolutely fine for conservative management. And conservative management would involve 6 weeks non-weight bearing in a plaster, then gradual increase in weight bearing in a boot. And it's important that we support the arch of the foot so we don't get latent instability for a period of 3 months thereafter. So now let's move on to our foobar foot patient. So this is the 46-year-old builder. He comes in on an on-call weekend. So the fundamental point here is the management of the soft tissues. It's not the bone that's important, it's the soft tissues. So if we're dealing with a major soft tissue injury and an open fracture, then the same principle of any open fracture applies, which is span, scan, and plan. A spanning fixator for the foot would involve, it looks exactly the same as a delta frame to the ankle, a Simon pin in the calcaneum, 1 or 2 pins in the first metatarsal, 1 or 2 pins on the lateral fifth metatarsal so that we can bring out both of the columns, and then a pin in the distal tibia to bring the ankle into a neutral position. So that is the delta frame for a midfoot injury. But of course, it doesn't have to be all open fractures. We can have severe soft tissue injuries which look like this, which is sanguineous blistering, and this will have a direct impact of when we can operate on this patient. This is a full thickness dermal injury, and in this situation, we must wait until this is completely settled down. So this could be 10 to 14 days down the line. If we operate through that, then it will be an absolute disaster. So should we try to reduce it if it's a closed injury? Well, my advice is don't bother, because even if you were able to reduce it, you wouldn't be able to hold it anyway. And in fact, the only reason to go ahead and do an acute reduction of these injuries is if a patient has a neurovascular compromise, or you are genuinely concerned that the patient is developing compartment syndrome. And if that is the case, then irrespective of whatever time it is or what day it is, you should be calling your expert foot and ankle surgeon to come in and advise. So now we've got the time to do a CT, and CT is useful for preoperative planning because you can pick up subtle cuneiform fractures that you couldn't see on the original x-rays, and that has a direct impact on what kind of implants you're going to use for the fixation. So the key thing here is do no harm. Do no harm. You've heard this before. Early fixation is absolutely fine if it's not too swollen, but in the main, most patients would benefit from waiting 10 to 14 days for the vascularity of the skin to recover. So the tip number 6 is, what's the best fixation method? In fact, this is not the right question to ask. The right question to ask is, what is the principle of fixation? So Myerson split the foot up into 3 columns, the medial column, central column, and the lateral column. And the utility of his classification system is that the medial and central columns are stable. They're naturally stiff, whereas the lateral column is mobile. So whatever we do to the lateral column in terms of fixation, we've got to make sure that we don't span the joint. So this is what a stable fixation looks like. Stable, solid, rigid fixation of the first 3 rays, and KY fixation of the 4th and 5th. It's always useful to do an EUA preoperatively once the patient is anesthetized on table, so we can actually judge the extent of the injury and how far it goes to the lateral side. So there are 3 surgical approaches depending on the extent of the injury. The first ray is approached by a mid-medial incision. The second ray by a dorsal-medial incision, and the thing that you need to be watching out for here is the dorsalis pedis artery and the deep perineal nerve on the medial side. On the lateral side, over the 4th and 5th metatarsals there, then you have to watch out for the intermediate branch of the superficial perineal nerve. But you can see you get a very good view of the base of the 2nd metatarsal. You want to achieve a reduction by using a large AO reduction clamp from the dorsal-medial side of the 2nd metatarsal. to the plantar aspect of the medial cuneiform to reduce that gap down and debride any bits that might be in the interspace. And then a home run screw. It doesn't really matter whether you put it from the medial side to the lateral side, or the lateral side, base of the second metatarsal to the medial cuneiform. It really doesn't matter. But the one tip that I would say to you is that if you are putting screws from the base of the metatarsals, and always countersink it down. Either countersink it or create a little trough, because otherwise one of two things will happen. Either you get an intra-articular fracture as you snug the screw down, or alternatively, as you snug the screw down, the joint will sublux. Then stabilize your first ray if there's instability, and the cuneiform is if there's unstable. On the lateral side, if there is a cuboid crush injury, it's really important to elevate it up and restore the length of the lateral column with a little plate and bone graft if necessary. So the question really is, what type of implant? Really doesn't matter. There's no evidence to suggest one way or the other, but there is an increasing move towards dorsal plating for these patients. And there are three reasons for that. One is it's much more versatile. So if there's comminution of the metatarsal basis, we can bridge that. There's a genuine concern that transarticular screws are causing chronic damage to these joints, but that has not been borne out in evidence. And also, because of the nature of dorsal plating, we can get better anatomic restoration. So you don't get this problem with subluxation when we home the screw down. But whatever's your poison, really, it doesn't matter, as long as you follow the right principles. So I'm not going to spend any time on this, because this is a most commonly asked question, but it's the most ridiculous one. And this is the classic example of this ipsedixism that Lyndon was talking about. Chris Coetzee popularized a treatment option, primary fusion for pure ligamentous injuries, and found better outcomes in his patients in 2007. And ever since then, everyone's been talking about primary fusion. But I would point out that there's a meta-analysis which was published 2 months ago, which clearly shows that there's actually no difference between whether you fix them, or whether you fuse them. So it is not something that really needs much further discussion. So finally, in terms of the postoperative management, we are talking about non-weight bearing mobilization with the plaster, then progressive weight bearing for 6 weeks, same as conservative, K-wires out at 6 weeks. And it's important to leave the metal working for 6 months so that we don't get latent instability if we take them out too early. But there is no absolute need to routinely remove them if the patient is asymptomatic. So in summary, the most important thing is diagnosis. Patient has a Lis Franc injury based on clinical symptoms. You want a high index of suspicion and investigate them accordingly. Weight-bearing x-rays, most useful. CT MRI scan, if you have any doubt about that. In terms of an acute injury, manage the soft tissues. Soft tissues, soft tissues, soft tissues, that is the #1 thing. And really, in terms of surgical fixation, doesn't matter what you use, as long as you get the anatomy restored. And don't forget, always listen to the patient and listen to what they are looking to achieve. Okay, I think that's the end. Pete?
I'm just there. Yeah.
Oh,
Cheers,
sure.
Hiro. That was totally awesome. Start my video. That was great. You nailed the whole topic there. Absolutely lovely. In the interest of time, I think we'll go straight to the Q&A. I'll make some comments right at the end. But Cesc, do you want to pick it up from here and just come for the Q&A? Microphone.
And there you go. And yeah, and also bear in mind that a lot of questions are being answered as we speak. So we won't get to reply to all of them, but the majority are being answered on the chat. So in terms of questions regarding the Lis Franc, there's a question saying, if we are keeping Lis Franc partial injuries in non-weight bearing, why we put them in plaster?
As opposed to?
I suspect.
Oh, yeah. So I know what the question is. So if the patient is non-weight bearing, why keep them in the plaster? Why not make them much more comfortable by putting them in the boot and instruct them not to weight bear? Absolutely fine. You know, that there's nothing wrong with that. I mean, you have to make a judgment about the patient and discuss it with the patient. You know, I don't think it's our role necessarily to make a judgment on whether the patient's going to be compliant or not. So yes, you know, I would certainly give the patient a choice. I think generally speaking, when you've got a patient with an acute injury, it is worthwhile just having that total stability and immobilization to make them a lot more comfortable and allow the soft tissues to settle down. So at least for a short period of time, I would always recommend a period of time in plaster. But if they want to come out and they are going to be, they understand the consequences of weight bearing on it, then an air cast walker is fine, I think.
Great. And then there's one about, what about an on-call weekend with no foot and ankle surgeon, frank dislocation of TMTJs? Would you advocate reduction and temporary wires? So
no. I think it's one of these situations where it's do no harm. Is have a clear algorithm. So if you are dealing with a patient who's got a major soft tissue, so open fracture, then yes, span scan, absolutely. If you've got a patient who's got a horrible looking X-ray, but there's a closed injury and the soft tissues are reasonable and the patient doesn't have any neurovascular compromise, then it's better to leave the patient, to allow the soft tissue to settle down and let somebody who has the capabilities to fix it definitively deal with it. Trying to go half-heartedly to do things like reduction and K-wires will commit yourself into a nightmare situation, essentially. It's one of these decisions that we think is intuitive, and when you actually get in there into the operating theatre, you just open up a whole can of worms, and then you've got a problem for the person that follows in dealing with with wires, which may potentially get infected, and then you've got wounds there that may be potentially in the wrong place. So I really wouldn't advocate it, unless there is a very, very good reason to do so.
Mm-hmm, mm-hmm. Yeah, there's a high risk with these injuries being crush injuries, that if you slice them early on, you run into a lot of trouble.
Yeah.
Okay.
Yeah. Pin site infection will basically completely roger your definitive fixation plans. There's nothing you can do then.
Mm-hmm. Mm-hmm. Jit and Lyndon, if there's anything you want to add as we are answering, everyone can contribute. Otherwise, we can move to...
Just on your point that Hiro made about K-wires, the only time that will be acceptable was the time that we've gone through recently, where you would bury the wires. If you were, if you're listening there, if you're going to do a first stage soft tissue resuscitation procedure, it needs to be close reduction and wires that you can actually cut and bury inside, that the next surgeon who comes in, who's a specialist surgeon, can pull them out 2 weeks down the line. And I've had experience once or twice where colleagues have done that before. It allows the soft tissues to resuscitate better. But, people should be able to put an X-fix on the foot as well. Majority of the people, guys who are practicing, they're able to put an X-fix and reduce the dislocation bit of it.
Mm-hmm. Great. And in terms of weight-bearing X-rays, do we do them both feet or single leg standing on the injury side? Lynn is saying both.
Yeah, both. Yeah. So it's always best to get comparative views. Or that may be a technical question about how weight-bearing views are done. So weight-bearing views are done usually sort of, you can do both feet on one plate on the AP view, but then on the lateral view, they're usually single stance. Yeah, with support on the side, and there's rails on the side.
I would say both feet as well. Just Hiro, it's like Hiro is saying.
Yeah, otherwise it's so hard to really assess that gap, right? And we can't let the radiologists cheat on that, because a lot of times we say weight-bearing X-rays, and then they seat the patient there and they take an X-ray of both feet on the floor, but you have to be standing for an X-ray, right? So that can happen too. Right. I think we're getting close to the end of the webinar, and the time is pressing. I don't know if there's any other question that's been asked that you want to comment on, or if you feel like we can go on to Pete's summary of all the lectures.
Yeah, you're good, Lyndon.
Yeah, no, I can pick that up another time. They was just asking about when do we X-ray post surgery. So I only commit someone to an X-ray if I believe that's going to change my management. So I'm usually bringing them out for boots somewhere between 4 and 6 weeks, down to wean them out, and that's when I'd get an X-ray.
Great, awesome. Okay, I think we're going to stop there. It's been a great session, and thank you all very much. Just first of all, massive thank you to our faculty. Nobody got paid for this. Hiro, Lyndon, Jit, and Cesc all turned up. Cesc, thank you so much for moderating with me and bringing some credibility to this. But all three magic talks, really, really good. Thanks very much. I'm now going to give a slightly village, non-scientific summary of the take-home messages that I've got from these things. And guys, if I missell your talks, feel free to interrupt me. Go, no, that wasn't what I said. We first started with Jit talking about medial malleolus, and what I loved about that was, if there's one take-home message here, it's the PTTL, that deep ligament, deep to the superficial deltoid, that only pulls tight when you're up in 90 degrees. So if you're down here, then your ankle is free to rock and sublux within the mortise. It's only when that comes up that it pulls tight. And it's only in that position you know whether you've got whether you've got talar shift or not. And so the gravity stress and the medial tendons, that's why that's moved out. And you need a plant. That's why the weight bearing works, because weight bearing inevitably puts you at 90 degrees with force going through it. And that's why that's turned into what it is. And that differentiates your 4A from your 4B. 4A, it's intact. 4B, it's gone. We talked about the isolated medial mal, how many of those can actually be treated non-operatively, provided it is genuinely an isolated medial mal. You've got to look at the top of the fibula. You've got to be examining the syndesmosis. You've got to make sure it is truly isolated. And there's lots of attention to detail with the surgery. So when we fix so many ankles, and I swear we do a lot of them badly, the positioning, getting it absolutely right so your x-rays are going to flow nicely, looking out for that superficial perineal nerve. Patients where you put a suture through that nerve, they are just livid with pain. They hate it. They get terrible RSD. And if you don't touch it, they're delighted. So often it's the tiny things that decide the outcome of your surgery. You can't get a medial mal reduced if you mal reduce the lateral side. If you just cannot get that medial side done, think to yourself, I'm going to stop on the medial side. I'm going to go back to the lateral, just make sure I got it right. Because if particularly the syndesmosis isn't right on that side, the medial mal will not come. Don't over tighten your medial screws and scrunch it in. We took lots of radiological signs that you're all aware of, that sort of Shenton's line of the ankle and the O sign laterally, and seeing the fibula, getting the fibular length right, as well as the rotation. Bicortical medial mal screws, we saw nice examples of that. And when you're fixing a medial mal, being mindful of tib post, and those difficult medial impaction injuries that you were talking about, and Cesc was talking about as well, where you've got to try and bring that medial impaction down before you put your buttress plate on. Lyndon then talked about posterior malleolus, a huge amount of science in here, really impressive amount of science and literature backing it up. But I think we would all accept now, even the hardest of traditional ankle surgeons would agree that X-rays are not good at describing a posterior mal fracture, and CT is the investigation of choice. And the whole percentage thing has been debunked, because you can have the whole of the posterior lip of the talus of the tibia off, and A, it doesn't really show that, it doesn't really seem that much on a plain film, and B, you've now completely lost that whole insertion, and yet it's still not quite 25 or 30%. Posterior mal fractures traditionally have had poor outcomes, but actually there's increasing evidence, and admittedly there's it's not all high quality, but there is quality in there for sure, is that as we're being more aggressive with posterior mal fractures, functional outcomes, not radiological ones, functional outcomes are being described as improved. The mechanism of injury of a posterior mal, I love that. So much of the, something that's cropped up again in previous webinars, and definitely in this one, is when you're talking about nuanced surgery and nuanced injuries, actually the mechanism of injury is often absolutely critical, and so it is with posterior mal. And Hiro was describing it in the Lis Franc as well, really nicely. So a type 1 is your PITFL avulsion, and type 2 is that rotational one where basically the talus has turned round in the mortise. And did you see the way you have a not so bad one where it knocks off the posterolateral part, and then the really bad one where it carries on going and then it knocks off the posteromedial part? So knocks off this bit, then knocks off that bit as the square turns in the otherwise curved mortise. ITFL is a broad insertion, and direct approaches do seem to be superior to indirect ones in early functional outcomes. One thing, just leaving Lyndon's thing, Lyndon has done some awesome, and I mean awesome, videos of surgical approaches and like the anatomy around the ankle, and those are going to be posted on OrthoHub over the forthcoming few days. So we're going to put those up so you can see. We didn't want to blow up the webinar with loads of those, but they're going to be there available. You can have a look at them and you can see exactly what they're absolutely spot on, really sweet. And then went to Hiro, talk about Lis Franc injuries. What I loved about this was 90% of the talk was actually not talking about totally smashed up Lis Francs and loads of crazy x-rays with wires and screws and plates and nuts and bolts. Actually, it was very much about diagnosis. We talked about some surgical principles to begin with, but really Lis Franc is about differentiating stable versus unstable. And because unstable in the ankle, you may be able to get away with non-op. In the Lis Franc, you really don't, unless it's a low demand patient. I'll come to that in a minute. But generally speaking, in a young active patient, an unstable Lis Franc does need surgery because otherwise the foot tends to collapse. So it's a ligament that's holding the foot there and the foot doesn't want to be there. So if you treat it non-op, it will tend to just drift down and collapse. And standard foot x-rays don't diagnose it. So, and again, same story. Your diagnosis of your Lis Franc is so often not in the X-rays; it's in the history and the clinical examination. And there's so much of that. I'm not going to read all of those out, but but you've got to get it out of the back slab. Listen to that. Get it out of the back slab. Have a look at it. Have a look at the plantar skin. And listen to the patient, listen to what the energy was. Remember, there is a low energy variant of a Lis Franc, which, as you heard, was that dorsal hyperplantar flexion, if you like. They've gone off the end of their foot and they've basically ruptured that dorsal capsule and dorsal ligament, and then it's propagated down and through. And that ends up, and that's when you do your piano key and it like goes, and it opens up that dorsal bit and it's like, ouch, there it is, boom, very nice. And all of the radiological changes, which I'm not going to go through. And then the progression of CT. When do we get a CT? Answer, when the radiological, the weight-bearing views are a bit equivocal, or, you're worried, but you're not absolutely sure. The CT is great for picking up subtle subluxations or little flecks or bits of bone or whatever. Who gets an MRI? I love the way we've now, I've clear in my mind, the person who gets an MRI is that high, much slightly high functioning, maybe an athlete, maybe someone who's an active sportsman who's asking a bit more of you. They want to really take their ankle to the very, very highest level they can. And MRI helps you categorize the injury and decide which of those ligaments have ruptured and which are intact. So you're titrating your treatment to your patient. High-end athlete, go for an MRI. What do you lose? It tells you exactly what's going on. Someone who's lower, who's low demand and isn't really asking very much of their foot, actually, you can lend towards non-op a bit more freely. And then we talked about severe injuries, and I love the way most of this was about the non-severe and the diagnosis. But the severe, I'm not going to repeat everything that Hiro said, but I liked a couple of things. I liked countersinking the screws was great. Rigid versus mobile sides to the foot. So the lateral side's a bit more mobile, so that gets K-wires. Rigid on the medial side. And the fixed versus fused thing, I think, is kind of like falling away now, and we're moving back towards fix. And I noticed that the panel were somewhat against a provisional fixation of K-wires, and that again, that's a nuanced debate. But if there's any take-home message for me for the more high-energy injuries, it is soft tissue management. That is the take-home message. Soft tissue management. You saw that lovely Delta frame that Hiro put up. both sides of the foot had X fixes on, and that was pulled up onto the front of the tibia so that the ankle was plantigrade. And you saw both columns being pulled out to length, and then you wait. And you can wait 2 weeks. You can wait 2 weeks for this hole to settle down before you charge in. Because at 2 days, all of that skin is degloved. And when you make cuts through degloved skin, it all dies. I thought that was a beautiful set of talks, guys, and thank you so much. Please bring your cameras back on, give us a wave, and we'll call this one quits. Cesc, just before we do, Cesc, is there anything I've missed out? Are there any bits that I've totally misrepresented, or I've missed an absolute howler?
I think it's very thorough, and I love these summaries. It's just bringing all the money into the end. Great.
Guys, thank you so much again, and we'll call it a night. Thank you very much. Just for the panel, we're going to move into a little chat room now where we can all drink beer and have fun. Okay. Thanks very much.
Good night, everyone. Thanks for coming.
Good night.
Right.